What physical therapists need to know about cartilage injuries. What's up, guys? Welcome to the Fitness Pain Free Show. My name is Dan Pope, and this is Kevin Coughlin. We are physical therapists at Champion PT and Performance. Like always, we're doing a literature review on a given topic. We're sharing what we find. We add our clinical expertise, and hopefully you learn a little bit. What's going on, Kevin?
Not much, Dan. Excited about this topic. I think this is one that sees us a lot, but maybe we don't see it. We don't notice it's there. And then other times it's very obvious when they come in with a pretty massive surgery. But I think it's a cool topic, and it was fun to go into the research on this one.
Yeah, I'm pretty excited too because it's one of those injuries that I don't see very frequently, and I'm not really abreast of a lot of the research on it. At least I haven't looked at it in some time, so I'm pumped to learn today. So,
Sweet.
you ready to get rolling?
Let's do it. All right. So just a little overview about what this presentation is going to cover, because we kind of have two parts here to cartilage, but we're going to go over a little bit of background, just get a freshen up on the different types of cartilage that we have and what we're talking about. There's a grading of cartilage lesions. So although this presentation is about cartilage, specifically, we're looking at cartilage defects mainly instead of broadly like osteoarthritis. That's such a big topic we'll probably dive into later. So more about cartilage lesions. The incidence and prevalence and mechanism of injury. We're going to cover concomitant injuries that often occur with cartilage defects, what the clinical presentation looks like, how to make a diagnosis in the clinic, and what tests or imaging you should look to order if you're suspecting one of these, what surgeries are commonly seen for these types of injuries, and for the different surgeries, when is one a better fit than the other. And I think a lot of good surgeons have a good grasp on this, but I think this is cool for PTs to start to understand a little bit.
Yeah, for sure. You know, without going too in depth here, one of the things I feel strongly about and what has really helped me as a clinician is essentially you can understand how a surgeon's supposed to think. You can guide the patient a lot better. You can also steer the patient towards the right type of surgeon, doctor, so on and so forth. Just makes that process a lot easier for the patient. And I think the other part is that it's a really good rapport builder. So if you know what's going on within the knee, the next steps, and then you have a good referral to a smart surgeon, I think that helps a lot for your patients.
All right, so just a little background. What the heck are we talking about when we talk about a cartilage defect? So there are different types of cartilage in our body. Obviously, we have hyaline cartilage, fibrocartilage, and elastic cartilage, and these are all a little bit different. What covers the joint surfaces in your different joints primarily is hyaline cartilage. So this is important just because when we're trying to think about different surgeries and what surgery might be best for your patient, certain techniques try to preserve or restore hyaline cartilage. Other surgeries induce an injury essentially that will lay down fibrocartilage, which is a little bit, they say, inferior to the hyaline cartilage. So, we always want to try to restore the native cartilage if we can. I think that's probably what we'll see when we get into the surgeries, the best type of surgery for long-term return to sport rates and stuff like that. But there's a spectrum here of different surgeries that we'll get into. But we're talking about damage to the hyaline cartilage, specifically in the knee, was what we'll cover today. In hyaline cartilage, it's a highly differentiated and specialized connective tissue. Its extracellular matrix is composed of water, mainly type 2 collagen, proteoglycans, non-collagenous proteins. It is avascular and aneural, so it doesn't have a great potential for healing. And that's kind of the problem that we see with this is once it gets damaged, it doesn't do a great job of healing. And depending on the grade of the damage, that's when we might think surgery is indicated. The thing is too, because it's avascular and it's aneural, it doesn't have pain receptors. So oftentimes these are asymptomatic. And we'll get into this, but it did remind me when we kind of did our dive on the rotator cuff, like at what point is an asymptomatic pathology worth doing surgery on, or is it ever worth doing surgery on an asymptomatic pathology? And that's definitely something we'll get into. But that is one of the things we see with cartilage is there can be quite a bit of damage without any symptoms. But oftentimes those symptoms may be related to the concomitant injury that they're dealing with. So just interesting things about cartilage. And obviously, the function of the cartilage is to decrease friction between surfaces. It provides a nice smooth surface to reduce friction and improve pain-free motion, and it resists wear in normal situations. The problem that we see also is that once you have some damage, it kind of lends to more and more damage. So oftentimes, you have an untreated meniscus tear or you have a meniscectomy, and that leads to oftentimes more cartilage damage, and that more cartilage damage can lead to more cartilage damage, and it's just this cycle that kind of begets each other. So that's why I really wonder, as more information comes out, how much of this asymptomatic pathology is something we should intervene on. We don't have great answers for that now, but we will cover it coming up.
Pardon the interruption, but I've got something that's going to blow your mind to smithereens. It's an evidence-based cheat sheet on articular cartilage injuries. Let's face it, staying up to date on all these topics, really tough as a physical therapist. Only psychopaths like me try to keep on top. And my promise to you is I'm going to catch you up to date on articular cartilage injuries under 10 minutes. We go over all the good stuff and none of the fluffy stuff. Background, incidence, prevalence, the grading of injuries, the association between ligament and meniscus damage and cartilage injuries, clinical presentation and diagnosis, which cartilage surgeries are going to be most prominent, like microfracture, OATs, and ACI. I'll let you know why you do one over the other. So click on the link in the description. This cheat sheet is 100% free. Like I said, my promise to you, catch you up to date under 10 minutes. Now, back to your video. Yeah, it is pretty interesting. In some ways, I think it's misleading and hopeful. One of the things you'll see in the social media world, obviously, folks are trying not to scare their patients. So as you lose joint space and you lose cartilage, you don't even know that's going on. And I think in the knee, the articular cartilage is some of the thickest cartilage you have in your entire body. So as you age, you're naturally going to have less joint space. It's probably one of those reasons why there's not a very good correlation between joint space and pain, right? And one of my thoughts being is like, yeah, if you have very little cartilage, that may mean that you don't have much pain, but does that mean that you're going to potentially have pain sooner, like you said? So I always feel like in the social media world, the pendulum swings a little too far, where like joint space doesn't matter whatsoever. But if you're like, late 20s, early 30s and very, very little joint space, does that mean that over the course of time, you're going to have some more issues? I don't really know. But yeah, just an interesting thought experiment, but it does make sense why you won't have a whole lot of symptoms when you don't have much joint space, as long as you still have some cartilage left.
Yeah, yeah. And like I said, it just reminded me so much of when we looked at the rotator cuff, because you see the same themes there, that tears don't really matter, but at some point they probably do. So it's just takes some nuance, I guess. And then just getting into grading of cartilage lesions. This grading system is from the International Cartilage Restoration and Joint Preservation Society. When you look at different papers, a lot of them use their grading system. It's really a group of medical doctors and PhDs who study this type of stuff, and they kind of put out a body of position statements just on what, how to best treat cartilage. They actually, I was looking at their website. They have a series of webinars that I think could be cool to watch just for practitioners to understand this stuff a little bit better. But just going through the grading quick. So grade 0 is normal, healthy cartilage with no damage. A grade 1 is what they consider nearly normal. So there might be some superficial lesions or softening of cartilage. Minor cracks or irregularities are sometimes seen, but there's not really a big disruption of the cartilage surface. Grade 2 starts to get a little more abnormal. Lesions extending down into less than 50% of cartilage depth. Fissures and defects do not yet reach the subchondral bone. So we'll get into this, but a lot of times when they're thinking about who to have surgery for, they're a lot more likely to recommend surgery when we get into grade 3 and grade 4. So just something to consider with the grading, but we'll touch on this in the future. So grade 3 is what they consider severely abnormal. So here, lesions extend through more than 50% of the cartilage depth, but not through the entire cartilage layer. It may extend to the calcified cartilage layer, but does not expose the subchondral bone yet. And then grade 4 is very severely abnormal. So here we have a full thickness loss of cartilage exposing the subchondral bone. And this is where people for sure start to get some pain, because we do have some more pain receptors in the bone, and you start to get some issues there. And I think this is when we see a bigger worry of this turning into a widespread osteoarthritis type situation. But that's just a little background on the grades.
Okay. Just so I kind of understand here, it seems like grade 3, grade 4 is where we have to be on the lookout for. Grade 1, grade 2, maybe not such a big deal, but once you get to 3, 4, that's kind of more important, right?
Yeah, and there's a cool paper coming up, kind of a current concepts paper, where some of the surgeons are recommending that grades 3 or 4 are probably something we want to start looking at for surgical options. I think the lower grades, we're thinking conservative care first, and maybe managing and checking these over time and seeing how they're progressing. But I think a lot of times what we see is people have grade 1 and 2, but they're asymptomatic. So probably more people have these than we realize. And I do start to think about that when I see people in the clinic, since just in the last couple of weeks researching this. I see people with meniscus tears, non-op meniscus tears, or post-op, and you wonder if they have some cartilage damage there that's just asymptomatic at this point. And I'm not sure it'd be managed so differently, but I think it is more common than we would think to have the grade 1 or 2. Okay, and then getting into incidence and prevalence. So these were based on 2 studies with kind of the gold standard way to diagnose. We will talk about this, is through arthroscopy. So if they can go in and look at the knee joint and just see what's going on, it's even better than MRI. MRI is really good. X-ray is not so good at catching these things. So based on 2 studies of knee arthroscopies, both had roughly 1,000 patients. They saw that somewhere between 60 and 70% had evidence of some type of articular cartilage pathology. That's not necessarily a defect like we're focusing on, but this could be things related to osteoarthritis, osteochondritis dissecans, or just generalized cartilage thinning. But based on those above studies, the incidence of isolated articular cartilage lesions or defects was about 30%. And so these were, I think, in not just athletes, kind of a whole spectrum of folks with a pretty big age range. So just to put it, they're saying globally, or on a population level, what are we thinking? Maybe 30% or a third of people have some type of cartilage defect in their knee, maybe grade 1 or 2 asymptomatic type thing. Based on that 30% of those, 32 to 58% were the result of traumatic non-contact injuries. 64% of these were less than 1 centimeter in size. So yeah, pretty small defect. And then 33 to 60% were greater than or equal to a grade 3 lesion in that grading system. So yeah, just something to consider. There's a whole range of these pathologies that you'll see out there. And, it's one of those things where I think a lot of them are asymptomatic.
Yeah. I guess one little question before we move on. Were these in athletes or just
So
regular folks?
So I think that study was a combination of both. That was from the clinical practice guidelines, the one with where they cover meniscal and articular cartilage lesions, I think from 2018. So I think that particular study was just looking at folks undergoing arthroscopy, not necessarily athletes.
That kind of makes sense because I wonder if you have more of a degenerative cartilage issue versus a more traumatic one, it's probably going to change the thought process somewhat, I'm assuming.
Totally. Okay, and then continuing with incidence and prevalence. So here we got athletes, Dan. So a systematic review of 11 studies. They had a total of 931 high-level athletes. Found the overall prevalence of full thickness focal chondral lesions was 36%. And between the studies, the range was pretty huge. So 2.4 to 75%. And this was a combination of asymptomatic and symptomatic patients. So not all of them had symptoms, which is interesting, even with that full thickness chondral lesion. In terms of location, where in the knee are most patients getting these? So 35% of lesions were in the femoral condyles, 37% were in the patella or the trochlea, and 25% in the tibial plateau. The prevalence of full thickness focal chondral lesions in asymptomatic individuals was 14%, but this number was substantially higher in basketball players and endurance athletes. they said 59% of the ones in this study had an asymptomatic lesion, and the range was between 18 and 63%. So I think here what we see is that depending on the sport, you could see more asymptomatic lesions here. Maybe it's a natural outcome of doing these sports for a long period of time, sports with kind of aggressive cutting and running and changing direction. Unfortunately, the natural history is not well understood, and this is a very tough part going through the research, is that we don't know how these asymptomatic lesions tend to progress over time. I think it's unclear, and it probably depends a lot on the individual and what they continue to do or what they stop doing. You could picture if someone has an asymptomatic lesion, they're a basketball player in the NBA and they retire. Maybe things are okay, but they keep trying to play through it. Maybe that's when it gets worse. Um, I think the best recommendations I was seeing was that to just keep monitoring symptoms. And if you find that you're failing a conservative rehab, that's when you consider surgery. We'll get way more into that down the road, but just something to consider. And again, yeah, most authors would agree that symptomatic defects are likely to remain symptomatic and possibly worsen over time. So asymptomatic, we may not be sure how they're progressing. Symptomatic seems to be challenging to treat conservatively. Sometimes they get better, but most of the time it seems they don't. And I think the pathology can even worsen. So good stuff.
I think that's actually a really good clinical pearl, right? So if you have an individual that you're working with, and let's say they're not getting better, you're not sure of what kind of pathology you're dealing with, probably do want to make sure you just send to the doc to figure out what's going on. Or if you know an individual has a cartilage lesion, then it's going to be tough to treat them more conservatively. And I think the other thing you had said, which makes a lot of sense to me, is that a lot of athletes just end up having asymptomatic pathology. And it kind of reminds me of, let's say, like a slap tear in a pitcher or potentially a hip labral tear in a hockey player. We know that a lot of folks are going to have these. It's just not always an issue, right? So kind of cool correlation.
Yeah, and I thought this was really interesting here, just because we see so many like ACLs and meniscus injuries at work. What's the impact of a meniscus and ACL injury on the articular cartilage? So there was a study by Brophy et al. They examined 725 knees with ACL reconstruction to determine the presence of chondral lesions and their relationship to a prior meniscus surgery. After adjusting for age, which was pretty cool, I think, knees with prior meniscectomy were more likely to have cartilage deterioration versus knees with no prior meniscal surgery. So I know when we did our series on the meniscus, if it's in a repairable spot and the surgeon can repair it, I think that's always the best choice, because I think it can even lead to other issues, not necessarily just a worsening meniscus tear, but it can lead to damage to the cartilage. So if we can preserve these structures in the joint, it's probably better all the time if we can. And then in terms of the ACL, so a delay in ACL reconstruction greater than 12 months was associated with increased incidence of medial meniscus and cartilage lesions. So I know this is something that, clinically we have to think about, is that someone comes in with a suspected ACL tear, they have a bunch of life stuff going on, and they want to know, can I just put this off and try to rehab conservatively? Or, this is a terrible year for me to get surgery. Can I wait? Potentially, but I think it's important to know that there is some potential risk to the meniscus and to the cartilage, especially if you're trying to do, I think, some aggressive things, like you're continuing to train at a high level with a non-op ACL tear. I think we're going to just have to proceed with caution. I definitely wouldn't say, like we went over, you can rehab an ACL tear, perhaps okay, conservatively, but just keep these things in mind, that it could make some of these other structures worse if things aren't going so well. I think, again, it would probably be something where you just progress based on symptoms. If someone's getting a bunch of pain and swelling as you're going through rehab, you could be making these structures worse. So just consider that. And then our guy, Kai Midhofer et al., a great surgeon out of Boston, noted that 50% of athletes with an ACL rupture also had associated cartilage damage. So that's like super high, right? I'm not sure I was aware of that. So whether that's somewhere on that grading scale, I'm sure a lot of them could be lower grades, but these injuries often happen together, right? A lot of times, I'm sure if we're getting bone bruising, a lot of times we must be getting some small amount of cartilage damage. So pretty interesting. And then Wyatt et al. Found the prevalence of cartilage injury was 2 times as common among those undergoing ACL revision versus ACL reconstruction. And, this is something I'll talk about coming up, but one of the biggest predictors of what your cartilage looks like is how many surgeries you've had on your knee. So having one ACL surgery probably puts you at risk for some type of cartilage damage, but then re-injuring and having another one is going to put you at even more risk. So when you see people who have had like 2, 3, 4 plus surgeries on one knee, I think more and more of the time we see those high numbers of surgeries, we should just assume that there's some cartilage damage as well.
Yeah, it's kind of interesting to think about the cartilage injury with an ACL, right? And we're going to talk about multi-ligamentous knee injuries in the future, which is also pretty interesting. But we do know that if you have ACL reconstruction, it's going to increase your risk of knee osteoarthritis. But just having an ACL injury is going to increase that risk. And it's funny, is it the injury to the ACL that's going to cause that OA over the course of time? Or is it an injury to the cartilage that's going to cause those injuries? And I wonder if they've kind of controlled for that in some of these studies. Essentially, if you have an ACL injury with concomitant cartilage damage, is that something that predisposes you to more osteoarthritis versus just like an isolated ACL injury? So kind of interesting stuff there.
Yeah, and I could be wrong on this, but one of the surgeons in one of the papers I was looking at was kind of saying that the reason why you want to achieve that quiet knee and really reduce the pain, the swelling, the temperature, I think all that inflammation going on in the knee is that when that's prolonged, it's not good for cartilage. Cartilage doesn't like that type of environment. That was my understanding of what he was saying. So, I think that maybe to your point, sometimes it could be a combination, like you get your initial ACL surgery, but if you don't get pain and swelling down in that person for a long time, it's probably doing something to their cartilage,
Yeah.
or they had an initial cartilage injury at the time of the injury, and that was why they had the injury. So I wonder if both are true and they have a different role in the progression of the cartilage.
Yeah, well said. And I think one of the takeaways maybe for PTs is that after you have a major injury to the knee, one of our priorities really is getting that knee quiet. So I think one of the things you have to be pretty cautious with is how much you push through pain wise. Because we know, and we see this with patients all the time, post-op knees, you go a little too hard, it makes them more painful, more swollen, more irritated again. So early on in rehab, if we're not smart, are we setting these patients up for more longer term osteoarthritis? So just an interesting thought to keep in mind when you're rehabbing your patients, I think.
All right. So then how are these patients presenting clinically? So most patients with articular cartilage lesions that require treatment, they present with pain with weight bearing. Makes sense. For more posterior lesions in the knee, they probably have a little more pain with end range knee flexion, whether open or closed chain. Pain can be localized to one compartment of the knee. So the medial or lateral femoral condyle. I think if you can get in there and try to palpate that a little bit, they'll probably have some pain with that. They might point to patellofemoral joint pain or tibial plateau pain. So I think palpation for trying to figure these things out is going to be pretty helpful. Swelling, and then the big thing that I said is they often have a prior history of a knee surgery. So if you see kind of diffuse pain around the patellofemoral joint, and you have someone coming in who's a runner, no prior history of surgeries, it's probably patellofemoral pain, right? It's probably not widespread cartilage damage. But if you have that same person coming in who had an ACL reconstruction a couple years ago and then had to get a partial meniscectomy, and now they're having some kind of grinding behind the kneecap, could be patellofemoral pain, but I think it would be wise to just consider it could also be some damage to the cartilage. So I think that history is kind of important, but otherwise, I think kind of standard clinical presentation we see with other intra-articular knee pathologies.
Yeah, it is kind of interesting. Someone has like a traumatic patellofemoral pain syndrome. It might not be patellofemoral pain, right?
Yeah. Yep.
And I don't want to steal your thunder, but one of the things that just you mentioned that makes me think about this is just that these seem to behave a lot like a meniscus tear. So if you have a posterior meniscus tear, like you said, you might have more pain with knee flexion. It might be a cartilage lesion. So it might just be something to put on your radar. So joint line tenderness on either side, kind of pain, end range flexion or extension seems a bit like a meniscus injury, but there's a chance it's a cartilage injury. I remember asking a surgeon about this at one point. How do you kind of differentiate between the two? He said it's very challenging. So I think all the more reason to send back to the doctor if you're not really sure. Then obviously they could do an MRI or potentially like looking for an arthroscopy, which I see very infrequently, but I had a patient recently that had an arthroscopy to diagnose and see if they were a candidate for actually a meniscal transplant. So they weren't. So kind of interesting. You will see that from time to time. And that is one of the things that docs will do.
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now.
Yeah, that's funny. I just saw that patient for you on Thursday. Yeah,
Oh, nice.
I was pretty interested in that. It would be cool if she was a candidate for the meniscal transplant, but yeah, such is
Yeah,
life.
unfortunately not. Yep.
Yep. Okay, so just getting into the diagnosis, how are we diagnosing this? So the clinical practice guidelines, they suggest making a diagnosis of articular cartilage defect with a low level of certainty when the patient presents with the following clinical symptoms. So acute trauma with hemarthrosis, so it could be within the first couple hours, an insidious onset of pain secondary to a repetitive impact. So either an acute injury or maybe they were just, they ran a bunch of miles and then all of a sudden their knees super flared up and they have some swelling and hemarthrosis. They get intermittent pain in swelling or a history of locking and catching. So some type of mechanical symptoms often accompanied with swelling and joint line tenderness. So I'm pretty sure everything I just said, like you had pointed out, is in line with a meniscal injury as well. So kind of hard to differentiate there. And then they threw this in. I didn't know there were Ottawa knee rules. Were you aware of that? Like the
Nope.
Ottawa ankle rules. So they just they just said, when should you refer somebody for imaging if they had an acute trauma? So if they're over 55 years of old, they have isolated tenderness of the patella, the tenderness of they have tenderness of the fibular head, inability to flex their knee past 90 degrees, and they can't really bear weight, especially like once they get to the emergency room for more than 4 steps. This is someone who we might refer for imaging, whether they fractured their patella or they had some type of damage to their cartilage acutely. So I think it's cool that's in the clinical practice guidelines, maybe worth keeping those in mind. But I think to Dan's point, this has a lot of crossover with other presentations, right? Someone comes in with ACL injury or meniscus injury. A lot of these things are true. Now, maybe there are some other special tests we can do for those injuries that we don't do for this. But I think the general theme of, is this someone you can treat conservatively that's responding well to conservative treatment? Then try it. If it's someone who you're really making no headway, the knee's super painful and swollen, and you're just not getting anywhere, refer for imaging. I think refer to a local surgeon is probably a good idea.
Yeah, that's all really interesting stuff. I didn't realize there were auto knee rolls, I guess. I guess my first question was, I mean, age over 55, if someone's over the age of 55 and have knee pain and they had trauma, I'm not always thinking automatically send to the physician. I'm kind of assuming that the sensitivities are basically if they're all zero, right? So there's, all negative. So it's all negative
Right.
as a good sensitivity. That 55-year-old thing just throws a big old wrench in the equation, though.
Yeah.
Um,
Yeah,
I guess
I think you're right on that. I think it's like if all those things are true, you should probably refer for imaging. I think of it like the Ottawa ankle rules, because I guess you just want to make sure they didn't have some type of fracture.
mhm.
But
Yeah, I can imagine if they've got tenderness to palpation of any of those areas and they can't walk. I mean, that's a good sign. You probably have to refer them in. So
yeah,
that's good stuff. And then hemorrhosis is just blood in the joint, right?
hmm
Yeah.
maybe seen with in terms of bruising or I'm sure something like that. We might not be able to have a good look at that in the clinic, but
Yeah.
it is a finding.
Yeah, for sure. And then I'm also kind of wondering, like things like a sweep test, probably potentially seeing some positive stuff there, just some
hmm
some fluid in the joint of some sort.
Okay, and then further for diagnosis, I kind of talked about this briefly, but radiography, getting an X-ray, it may be helpful for assessing joint space related to osteoarthritis, and that can be helpful for surgeons determining which cartilage surgery they should or shouldn't do when they're
Mhm.
looking at the joint space. But it doesn't do a good job grading these cartilage defects. So the gold standard diagnostics are arthroscopy is the best, and then MRI is really good too. And what they're assessing for is the size of the defect, and they're also looking to see if there's widespread damage to the cartilage, because if you have someone who has a pretty gnarly defect but they also have general widespread OA, they're probably not going to bother repairing the cartilage defect. They're going to think about how to treat this from an osteoarthritis standpoint, and that might require a total knee arthroscopy. So that's kind of their algorithm there. But MRI or arthroscopy, probably MRI first. And then if they see something pretty significant, I think they would go in and either do an exploratory scope or go in and just assume that if we find something, we're going to do this planned surgical procedure. All right. So getting into the types of cartilage surgeries. So there's really three treatment strategies, and I'm sure there's actually more than this, but I think in terms of like the main surgeries that you'll see as a PT, we see like a palliation type surgery, so a chondroplasty and debridement. And this is really where they just go in and clean things up and they try to reduce mechanical symptoms, if they think that's really the cause there. I won't talk about those couple procedures that much. For repairs, they go in and they can do some drilling or perform a microfracture. So microfractures are very common. I think this is one that we see a lot, and they do in conjunction with other surgeries sometimes. And there's a certain population that it's best for. So we'll talk about that. Restoration techniques are really the other big one. And these are pretty big, impressive surgeries. So one is referred to commonly as the OAT, and that's an osteochondral autograft transfer. Another one is referred to as the ACI or AC, autologous chondrocyte implantation. And then the other big one that really is being seen more recently in the research. I think any paper I was looking at before like 2020 didn't mention the MACI. It really just talked about the AC. But the MACI is a matrix-associated autologous chondrocyte implantation. So another big surgery here, and one that we see, I think, a little more frequently now.
Yeah, kind of to your point, when I was in school, we learned about the ACI, AC, whatever. Never learned about the MACI. And my first patient that had one, I was like, did they just sneak that extra M in there? Like, what is the deal with this, right? But apparently is a different thing, right?
Yeah. All right. And then let's get into some surgical indications. So why would they perform each of these surgeries instead of doing the other one? So for a microfracture, the indication is small, so less than 2 centimeters squared, full thickness cartilage defects in younger individuals, usually those less than 40 years old. It's for smaller lesions that don't extend into the bone. For the technique, they drill holes into your bone marrow and it stimulates healing. But the thing is, it creates the cartilage it creates is fibrocartilage. So this technique does not re- repair or bring back your native hyaline cartilage. It replaces it with a fibrocartilage, which is strong and I think does a fairly good job. But they often note that it's just not as good as hyaline cartilage. I think there's a reason why your body put that there. One of the pros of this surgery is it's easy to perform and you can get some pretty good pain relief, and the recovery is pretty easy too, as well. The cons is that it's not good for larger lesions. It's not great for older adults. It's definitely not great for those returning to a higher level of sport. And the fibrocartilage is inferior to the hyaline cartilage. So just consider that. This quote was from a study published actually in 2025. I wasn't able to get the full paper, unfortunately. So I was just looking at the abstract, but it was pretty much in line with a lot of the other things that papers that I was seeing. And if you're a member of the sports section of the APTA, they have this paper coming up for one of the journal clubs with, I'm blanking on his name, but Phil Page and your buddy who is on the podcast here.
Mansky?
Mansky. Yep.
Yeah, just
Their
saw
journal
Mansky this
club
past
is,
weekend.
yeah. Oh, awesome. Yeah, their journal club is focusing on this paper as well as a couple others. So it's like really cool timing. It's a big cartilage one coming up this month. So to date the episode, you could check it out. But they said here, undergoing microfracture was associated with consistently poor return to sport ability. So, if we're thinking when we see this, hopefully this is in somebody who is just trying to get through life pain-free. Maybe they like to exercise a little bit, and they're looking for something to relieve their symptoms, but they're not somebody who's trying to get back to college soccer or college lacrosse or something like that. I have seen it in a few people where it was seen that they had some cartilage damage at the time of an ACL reconstruction and they did a microfracture. I wonder if that's a slightly different scenario. And I think some surgeons would have some good insight on this, but generally this isn't for your higher level athlete.
Yeah, it is kind of interesting. And I will say I used to see some more microfracture patients. I haven't seen any primary microfracture patients recently. I wonder if this is the reason why. But what I will see oftentimes is someone has some sort of injury for something else, and then the surgeon will do a little microfracture here and there. And I'm assuming that it's not very much, like you had said, small bit of damage. Like, well, this may or may not be an issue. Let's microfracture it, get a little extra cartilage in that area. Maybe that will help to enhance outcomes or reduce like future osteoarthritis, something along those lines. So that's kind of where I end up seeing it, is with someone had a different injury, they get surgery for something else. Maybe they add a little microfracture in the mix just for funsies.
Yeah, I totally agree. That's where I've seen it too recently. I've never seen a microfracture in isolation. So
Yeah.
yeah, kind of
But I do
interesting.
remember when it kind of came on the scene and you'd have professional athletes that would get a microfracture surgery, and it was kind of a big deal. So maybe we're coming a little bit more full circle and seeing now that maybe it wasn't the best surgery, but kind of interesting just to be, along for that and seeing that.
Okay, so just continuing here on the microfracture, just a couple studies that were looking into this a little bit more. So Goyle et al. Reported on 6 studies with long-term and 9 studies with short-term follow-up using the microfracture. And what they consider small for a defect kind of depends on the paper you're reading. Some of the surgeons call less than 2 centimeters squared small. Some are calling less than 4 centimeters squared small. So just consider what paper you're looking at. But they were saying in this particular study, small was less than 4 centimeters squared versus a large was greater than 4 centimeters squared. And they were comparing microfracture to the AC and the OAT. And the findings were that the use of microfracture for the treatment of small lesions in patients with low post-op demands led to good short-term clinical outcomes. However, greater than 5 years post-op, treatment failure could be expected regardless of the lesion size. So that's a little disheartening. So maybe not great long-term success here. And the conclusion was it's best for small lesions in younger, less active patients. So kind of in line with the guidelines from the previous slide.
Interesting. I wonder if it has something to do with the type of cartilage, right? Maybe fibrocartilage is not what was meant to be inside your knee joints, right? That the area takes a whole bunch of strain, stress. So I'm not sure if that's one of the reasons, but kind of interesting thought experiment.
Yeah. Yeah. It kind of seems like that. Yep. All right. So getting into the OAT. So this technique, they have cylindrical bone plugs and cartilage harvested from the non-weight bearing area of the joint, and it's transplanted into the defect. So they'll open up your knee, they'll take a bone plug from a non-weight bearing part of your own joint, and then they'll transplant it into the defect that they're working on. This is indicated for small to medium cartilage defects. So not the largest ones. That's saved for the one that we'll talk about next. But small to medium, they tend to use the OAT, similar to the microfracture, but this is better for returning to higher level activity. So athletes, this quote was taken from one of the studies above. Athletes have higher levels of self-reported knee function, return to sports, and maintenance of activity versus those with microfracture or with ACI. Sorry, so better with the OAT or the ACI for higher level activities. The pros here is that it provides the patient with their native hyaline cartilage. So instead of the fibrocartilage seen in the microfracture, you actually have the hyaline cartilage here, which is better. The cons is that it's limited by the donor site availability and the tissue health, and it may lead to long-term issues. They're kind of unsure on that, but it does seem like long-term outcomes are pretty good. But if you have someone with a defect and there's no really good donor site in their knee because they have kind of widespread cartilage thinning, they're not going to be a candidate for this surgery. So it does require probably that young, healthy person with otherwise healthy knee who happen to have a defect with some type of traumatic injury. And it does seem to do well. We'll talk about outcomes in a future episode, but it is a pretty cool procedure.
One thing I will say, because the first time I heard about this, it was a little bit confusing, but there are actually areas in your knee that are non-weight bearing and have cartilage. So essentially, they're taking cartilage from a non-weight bearing portion of your knee, right? I think the other thing that I learned at some point is that you can only take so much cartilage because there's only so much cartilage there. So if you have a particularly big injury, there's not enough non-weight bearing cartilage to grab. So I just thought that was an interesting little addition that I learned at one point. So
yeah, that's a good way to remember it. I think that makes sense because, it's really like the AC and the MACI that seem to be for bigger defects. And yeah, to your point, you only have so much non-weight bearing cartilage you can give. So if it's a larger defect, that might not be a good candidate for that. So getting into the AC, when would this be used? So, the technique here is cartilage cells are harvested from the patient. They're cultured in a lab, and then they're implanted under a periosteal patch back into the knee. This is best for patients younger than 50 years old, active patients with an isolated cartilage defect, and they have otherwise normal anatomy, normal joint space, that type of thing. They're indicated for more of a medium to large defect, kind of like we were just saying. So what they considered here was somewhere between 2 centimeters squared and 10 centimeters squared, which is huge cartilage defect. The pro of this type of surgery is it generates the hyaline-like cartilage, and it's suitable for larger lesions, which is awesome. And you can generally return to a higher level of sport, which is good. The cons is that it's a two-stage surgery. So first they have to go in and they have to harvest your cells, and then they have to culture them. And then you go back in for the actual surgery. And given this, it's a longer rehab. So this takes quite a bit of time. We'll get into the prognosis and return to sport time again in a future episode, but it is a longer rehab. So that is a little bit of a con as well.
I do kind of wonder, and I don't know if you're going to go over the MACI and this will be different, but it seems like for a lot of these, they're not really suitable for older patients, right? And one of the things I'm kind of curious about, and it just reminds me of, let's say, FAI surgery or PAO surgery. We used to kind of think that, you shouldn't be doing these surgeries in older individuals. And then kind of later on, we found that it's more about your joint space. So if you're over the age of 50, 55, you're more likely to have less joint space, maybe a little bit more beat up knee. I'm just curious if like the outcomes are a bit worse because there's additional pathology going on, or there's something about being older that, doesn't agree with the surgery. So do you find anything like that, Kevin?
No, but you saying that is very interesting. And I think that probably seems, I would guess that's true, right? I would think if you have I'm not sure anything, magical changes with age, but if it correlates with less healthy cartilage and joint space, then they use age as a proxy, but maybe each individual varies a little bit. And that is something cool to see over the course of time. I think our older populations are getting healthier and healthier, and maybe we'll see more of this type of surgery as we get older, and people like us, hopefully.
Yeah, well, that was my first thought because we're seeing so many super fit and athletic folks that are aging.
Hmm.
And I think classically, a lot of these folks are told not to pursue some of these surgeries and just like really lower the amount of activity they're doing. And that's not great, obviously. We want people to stay healthy over the course of time and obviously really favor fitness. And then one of the things that, we both found over the course of time, especially doing this podcast, is that one of the reasons why they may have these recommendations is because we don't have research yet. So I
Hmm.
wonder if they control for these variables, because usually, at least from a historical perspective for FAI and PAO, they're like, oh, look, age over 50, that's a contraindication. And then later on, as they did more research, they found, well, it's not really the age, it's the amount of joint space or so on and so forth.
Mm.
Just kind of curious, just because, we were guiding people down the wrong pathway simply because we didn't have the data yet. I wonder if this is similar. Hopefully it is, right? But who knows?
Yeah, and I'll just say quick too. I think what you want to do is delay or avoid a total knee replacement because even though you can get back to some pretty cool activities with that, I think you can get back to higher level things with an AC or a MACI. And if you don't do this surgery on an older person and you kind of wait until they need a total knee replacement, that's a little bit of a tougher situation to do all the things that you love doing potentially. So yeah, hopefully that does change a little bit over time. That's interesting to think about. So then just getting into the MACI. So the surgical considerations are very similar to the AC. And I think generally what we're just seeing with the newer research is that it's almost replacing the AC. I think it's just if you're a candidate for that and the surgeon knows how to do the MACI and has experience with it, they're going to probably just do that instead. The technique here is cartilage cells are harvested from the patient, cultured in a lab, so similar to the AC. But then they're implanted or they're cultured in a bioengineered collagen matrix scaffold versus the periosteo patch seen in the AC. So it's a little bit different the way that they're harvesting and scaffolding your cartilage cells. And it just seems like this is perhaps a better medium for those cells versus the periosteal patch. I think it's leading to slightly better outcomes. So I think you could think of it in your head if they're a candidate for the AC, then they're going to be a candidate for the MACI. I think it goes hand in hand. It just depends on the surgeon's skills and preferences, I think. So similarly, the patient population is younger patients, but we'll say maybe patients with good joint space instead. Um, and then active patients with isolated cartilage defects and otherwise normal anatomy. It's for more of that medium to large size defect as well. And then the pro is again, it generally generates your own hyaline-like cartilage suitable for large lesions and medium-sized lesions. It is a two-stage surgery, and the rehab is slightly longer than the OAT, probably a similar timeline to the AC, but we'll get into that in the future.
Also, just kind of interesting, like you said, I haven't seen any ACIs, but I've seen a couple Macy's, and I
Hmm.
wonder if that's just the same thing. The surgeon's like, it's a better procedure. ACI is kind of going away, but that's just been my experience. Doesn't mean it's everyone else's, but just interesting to think.
All right, and then just to summarize those, because we'll talk about those in a future episode, but the microfracture broadly is best for smaller defects with lower demand patients. So, someone who might not be getting back to higher level activity, they really just want their symptoms to be a little bit better. Maybe buy some time before they think they need a knee replacement or something like that. A microfracture could be suitable. The osteochondral autograft transfer or the OAT, it's best for small and medium sized defects and patients with high activity demands. Or they have bone involvement. They do say that because it's osteochondral, so they are taking bone plugs. And maybe if you have a pretty bad bone bruise and some cartilage issues, that's a good surgery for that type of person. And then the AC and the MACI, better for, I think, your medium to larger size defects, especially in younger patients with good joint integrity and patients trying to get back to high level sports. So kind of the big surgeries. It was fun to research these things and learn a little more about them.
All right, now you guys are experts with cartilage injuries within the knee. Well, sometimes those cartilage injuries are not cartilage injuries. They're actually meniscal injuries. So we have a video for you. I'm going to leave a link in the corner right by Kevin's head there. It's what physical therapists need to know about meniscal injuries. Go ahead and click on that link and I'll see you there.
If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain-Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I added to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.